Welcome to OVIDcasts. I'm Roudie Shafie. I'm a partner here at OVID Health. In our first season, we have a limited series in discussion with Professor David Salisbury. Welcome, David.
Hello.
So David is a former Director of Immunisation at the Department of Health here in the UK. He's now the chair of the WHO Committee on the Eradication of Polio and an Associate Fellow at Chatham House Global Health Programme, and of course, a Senior Associate here at OVID Health.
Hello.
Great. So, David, why don't we kick off with a big picture question? What's exciting you right now about the vaccines world and the development and what's coming down the pipeline?
I think we're really at a sort of transformative moment in vaccination. Everything is changing. We're changing how we make vaccines from classic traditional processes to completely new ways of making them. The RNA vaccines are a complete change. So we've got new technologies. The way manufacturers make vaccines is changing, so that instead of having to have an enormous factory that does everything from the early development through to printing the labels and putting the vaccine in boxes, now a whole lot of that gets farmed out so that people are breaking up the steps and then getting other people to do them. And that's changing a lot of the time that it takes. The regulators are changing the way in which they approve vaccines, so that instead of waiting till the whole of the package is ready for review, they're prepared to look at it in sequential steps. Now that makes the whole thing quicker and indeed more efficient, in that you get the final result of your, is the vaccine safe and effective, more quickly. So everything is changing in the manufacturing side. And I think that one of the things that's come through from coronavirus is that we're able to access more people more quickly, more accurately. We have better data, both collected about people and their vaccinations, that makes the whole thing more efficient in the future. So I don't think there's one thing that's changing. I think that there's a great deal that's changing. And what's happened from coronavirus, of course, there's been a terrible price to pay economically and in human terms, but it's given us an opportunity to really move vaccines forward fast.
David, that's great. I know here in the UK, you were a real reassuring voice on the radio many a morning around the COVID vaccination program in particular. And one of my favorite things you used to say was, to have an effective vaccines program, you needed a vaccine, you needed people to be vaccinated, and of course you need people to deliver the vaccine. So you've talked about the development of new vaccine, of course, you know, the data that we can now collect to find people and ensure they're coming forward and are vaccinated. So what about the third dimension? You know, what are we seeing globally in terms of, I guess, health infrastructure for vaccination, both in the developing world, but also more advanced economies?
Well, the infrastructure, the delivery part of vaccination programs is always going to be a challenge wherever you are. And those challenges come from different reasons. They may come from people who are hesitant about coming to be vaccinated. It may come from social determinants, that some people are not very well in the system that identifies them and allows them to benefit from health programs. And as you go down from the industrialized to the middle income to the lower income countries, some of those are exacerbated and are much more difficult to deal with. So the delivery side, in all circumstances, is a challenge. And sadly, in the lower income countries, sometimes those challenges are even greater, but they're not insoluble. And I think we have to take a positive view that you can provide vaccines. And although I keep coming back to this, you know, getting polio vaccine is a bit like getting Coca-Cola to every child on the planet. And if we can do that, we ought to be able to do that better for our routine vaccines, not just campaigns, but every child, every adult ought to have access to the vaccines that they need. and affordability needs to be dealt with as well.
Great, excellent. Thank you very much. It's interesting you mentioned sort of social determinants. In the UK, as in many other countries, there's a real zeitgeist around health inequalities. Of policymakers, of course, in the public health context, but also charities and companies are now much more aware of it. So what do you see as the role of vaccines in addressing health inequalities?
I think vaccines are the great leveler, in that the purpose of many vaccine programs is to be ubiquitous, to make sure that every child gets vaccinated. And that means every child, irrespective of their circumstances. And for programs for older people, it's every person. For example, for flu vaccine, it's every person over 65. And we need to find ways of ensuring that ageism doesn't actually become a barrier, and that some of the determinants that go with age and access to healthcare can be overcome.
Yeah. And are we seeing any data? So for instance, in the UK, we often see data around health inequalities having a north-south divide, or even in London, for instance, we see an east-west divide. There's a famous statistic about how many years of healthy life you lose as you travel on the Piccadilly line from east to west. Do you think there is a geographical kind of element to vaccines health inequalities at the moment?
I think there is, and the reasons may be multifactorial. It's rarely one thing. It's big families with less income, with less support, with not the same language skills. So it's not one thing, it's many things, but many of them are fixable. And we keep turning to vaccine hesitancy as if it's some issue of rejection of vaccines. But there are many causes why people don't get vaccinated, and access and the attempts to deal with inequalities, I think, are probably more important. Great. Numerically.
Yes. And I remember recently we had a really interesting kind of policy debate in the UK around HPV vaccines for boys, and sort of the health inequality potential impact of that versus the other, cost effectiveness impact of it. Do you see any other vaccines coming down the pipelines that you think will again challenge the sort of vaccines landscape here?
On the issue of inequalities of gender, then I don't think so. I think that HPV was one on its own in a way, and that I do understand the logic that started vaccination for females. It got complicated because of cost effectiveness. And it's an interesting debate, and I think there's a long way to go with that debate between how you value cost effectiveness in equity. What is the value of equity? If the cost effectiveness is driven by the narrow benefit in health, then you can see why female vaccination was the first place to go. But when you then try to say, well, what about vaccinating males on the basis that we should be giving them exactly the same opportunity that we give to females, then how do you value that? How do you assign a monetary value to equity when it may not be dealt with in conventional economic analysis? Tricky.
Indeed. And do you see anything else coming down the pipeline that will also, not just on the grounds of equity, but in other ways, sort of challenge the existing kind of vaccines landscape in the UK? So, we've often heard thinking around a cancer vaccine. Obviously, that's what HPV is the beginning of. Are there anything else that you think would really kind of change the way we approach certain diseases?
No, I think that the principles will carry across for all of the vaccines that we use and that we will use. And I think that we will be looking at vaccines for older people. There are undoubtedly going to be more of those. We will be looking at childhood vaccines. And I think in every one of those cases, we have to do our utmost to make sure that nobody misses out who should indeed be protected.
Great. Well, what a great place to end our first conversation. So thank you very much. This is the end of episode 1.